Welcome to tonight's Ask the Expert session on the professionalism topic of treating staff, family and friends. In the spirit of reconciliation, Avant acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I will hand you all over to Ruanne Brell, a senior solicitor here at Avant, who will moderate our webinar. Ruanne.
Thanks, Sterling, and welcome to everyone, and thanks so much for joining us tonight. I'm going to be talking to you this evening together with Dr. Patrick Clancy, one of the medical advisors at Avant. So we're hoping to give you a good balance of clinical and the doctor's perspective and also the legal perspective. And as Sterling said, feel free to jump in and post questions as we go along. Often the best place to start is in looking at what's, a sort of a real life event. So let's start with a scenario of Simon. Simon's a 9-year-old boy and he went to the hospital with his dad, who was a health practitioner. And he was there on a social visit, but while he was there, his dad saw one of the paediatricians in the ED socially and just said to him, oh, look, actually, I'm a bit worried about Simon. He's been a bit lethargic for 3 or 4 days, had some mild flu-like symptoms, and now he's got a bit of a rash. The paediatrician had a quick look, thought he had a viral illness, but said that it might be scarlet fever or tonsillitis. Neither of them made any notes or documented the visit in any way. Unfortunately, Simon's condition deteriorated the following day and his dad took him and formally presented to the emergency department. Unfortunately, there was, of course, no documentation about that previous visit, which did influence the history. And ultimately, unfortunately, Simon passed away and it was determined that this was from sepsis superimposed on influenza A. A bit of a sort of maybe a confronting way to start this evening, but it's a really extreme example, but a good example of just some of the issues that we face in this situation. And that scenario is actually based on a real case. And in that case, the coroner found at the inquest that the request for the doctor to see the child informally put that doctor in a really difficult position. The doctor was expected to do a quick consultation, to do it on the fly, without making any notes. The doctor was sort of reliant on the father's sort of clinical input as to what was relevant and what wasn't, without necessarily assessing the boy in the same way that you would any other patient who you might see in that situation. And that not only it might have been directed in terms of the information given, but also maybe even suggestive about the actual sort of possible diagnosis. So this is sort of where we start in a real case. And tonight we'll sort of be looking at the issues that come along in these sorts of situations in a number of different contexts, treatment and prescribing, and looking at why this is seen to be a concern and why there's some guidance around it. So there's issues about objectivity, there's issues about difficulties and awkward situations that you might find yourself in. And also, as we saw in that case, a lack of continuity of care because things are done in an informal way as well. And this can have adverse impacts not only on the patient, but also on you personally and professionally. It's a good idea to consider where the boundary might be, and that's going to be different depending on different circumstances. Please do use the chat function, as Sterling said, and interact with us and give us feedback or ask questions as we go along. One of the reasons why we run sessions like this at Avant is, as Sterling said, we have seen an increase in sort of what we call professional conduct claims, so complaints to the regulator. And we can see here in Avant's data that treating family members or a close friend was one of the issues that was brought up in a lot of those claims, which we call it's a professional boundary issue. So of the top 3 issues that you can see there, treating a family member or a close friend was the one that was most likely to be substantiated in a subsequent case. This is based on almost 400 claims involving these boundary issues over the last 3 or 4 years. And this is one of the things that we do at Avant to learn and be able to educate our members from the experience of others in a claim. So to kick things off and to get you interacting, we thought we might ask a poll question, which will be just whether or not you prescribe for family or friends. If you could just indicate yes or no in there. And Pat, while everyone's coming in and putting in their answers, what's the experience of most doctors, particularly when they're starting out in practice?
Yeah, thanks, Roanne, and good evening, everyone. I think I started getting a request for advice from friends and family as soon as I got accepted into medical school. I think before I'd even made it to the first lecture on the first morning. And those sorts of requests just kept on coming right through uni. And then certainly once I had qualified as a doctor, then there were lots of requests from lots of people, requests for scripts, requests for referrals, requests for advice, or requests to even just sort of be the treating doctor on the sly almost. Even just last week, I'm still getting them. A good example, last week I was at one of my kids' sporting games, and one of the mums decided she needed to ask me all about her gynecological history and whether she'd had the right sort of management, the right sort of advice from her specialist that she'd seen the week before. And that was pretty confronting to be doing that on the side of a footy field. And we do get a lot of pressure to have some sort of involvement in the medical care of family and friends. And the extent of what we're being asked can vary, and the extent of what the family and friends realise we can do or will do also varies. I have found that lay people, not non-doctors, a lot of them genuinely have trouble understanding the whole reason why we can't just step in and be their treating doctor whenever we want to and whenever they want us to. I've had debates with my own family. How come they're allowed to come and look at my car and try and sort that out, but I'm not allowed to treat them as a doctor? And why they can't get scripts for whatever pain relief they think they might need because they've got a sore toe. So sometimes we get a simple chat about the treatment they're getting, but if you're really not careful, that can rapidly progress into more significant problems, which we'll see.
Yeah, thanks so much, Patrick. So I think we've got those results now. And thank you everyone for responding. So almost 60% of you said that you do or have prescribed for family members, and 40% said no. So we're going to look in now at some of the sort of the reasons why you need to think before you do any of those things. So Pat, one of the things that the starting position here is maybe what guidance can doctors use to sort of help them navigate this situation? Are there any guidelines about this issue?
Absolutely, which I think they're just up on the screen there now. The medical board has a code of conduct called Good Medical Practice. When you renew your registration every year, even in New South Wales, you tick a box to say that you will abide by the code of conduct. And there are things in there specifically addressing management of anyone who you've got a close personal relationship, which is your family and your friends and probably your close colleagues as well. And generally it's inappropriate, and they go on to actually outline the reasons why, which is quite unusual to have a document where they're justifying it as opposed to just telling us not to do it, which is actually quite a helpful guide then. They say there's a lack of objectivity, there's possible discontinuity of care or fragmented care, and there are risks to the doctor and the patient. They do specifically talk about S8 medication, psychotropic medication, drugs of dependence, and performing things like elective surgery on anyone with whom you've got a close relationship. They do acknowledge that sometimes it's unavoidable, life-threatening emergency, obviously something does need to be done. My recommendation, and putting a spin on that, is that it really does need to be a genuine emergency and there's nobody else immediately available, rather than sort of thinking, oh yeah, maybe it's a bit of an emergency, but to be honest, it's really just quite convenient if I do step in and do stuff here.
Thanks, Pat. And that specific wording about not prescribing Schedule 8 medication is one of the things that was added into this revised section late last year when the code was updated. So if any of you haven't read the code recently, or certainly if you haven't read it at all, we'd certainly encourage you to jump on the Medical Board's website and familiarise yourself with the code. And in terms of prescribing, it's one of those situations which can start the slippery slope into sort of over providing care for family members. Again, in a recent case that was looked at by the regulator, there was a very experienced practitioner who was caught in a really difficult situation with her daughter who was in distress. And she started by prescribing some S4 medications for her daughter. But in doing so, she didn't inform her daughter's usual treating practitioners about what she was doing, including her treating psychiatrist. She didn't secure her script pad, so there was a question raised in the case about whether or not actually all the prescriptions had indeed genuinely been written by her. And when she was concerned about the level of prescribing, she actually then was tempted to prescribe in her own name and in other family members' names rather than solely in her daughter's name. So she actually sort of almost worsened her professional misconduct from that point of view. And because she had put herself in this treating relationship, it also led to her providing a medical certificate for government purposes for Centrelink for her daughter. And in there she was didn't properly represent the role that she was playing in her daughter's treatment. So it caused even greater concerns for this practitioner. So again, it's a good example where whilst you might be motivated initially from a sense of wanting to help, it can really lead to some challenges, and that practitioner was reprimanded and had to undergo a series of education, and it had an ongoing impact on her ability to practice. So staying on prescribing for a moment, Pat, as you were saying, there is some guidance and discussion about, when it might be unavoidable or what might be an appropriate circumstance where you might consider prescribing for a family member or friend. What are some of the circumstances that we might consider doing that? And any of you listening, feel free to jump on the chat and send us your own thoughts about when you might think it would be appropriate.
Yeah, well, we did already cover off on whether there's an emergency and a genuine emergency, and that's also been a few people have submitted that in questions to us as well. So absolutely, if there's an emergency, then you can't compromise patient care. Obviously, you've still got to be objective when you're doing it, though. Also, we do see it a bit in regional and rural communities. Now, I know physicians aren't necessarily ever going to be faced with the challenge where they're the only doctor in town, but sometimes you'll be the only person in that specialty in a regional city, and basically you're it. So sometimes that is appropriate. It is a horses for courses for thing, and certainly the regulators in looking into that would take that into account. Just how accessible was it to send someone to the next big city, whether it's 5 minutes down the road or 5 hours down the road, that really does make a big difference. And similarly, when there's nobody else available until you can hand off that care to somebody else to do it properly, and do it objectively at arm's length. So with that, we might just work through a case study. It's based on a real case. Yet again, it has been de-identified. And while we're working through it, just want you to have a little think about things like what would you do in that situation yourself, and when you think professional boundaries might have been crossed, and what you could do to avoid the situation occurring. So the case is Phil and Sarah. Phil and Sarah are friends. They regularly play tennis together. There they are playing doubles. Sarah's an endocrinologist, and Phil's got his own small manufacturing business. Phil takes esomeprazole or Nexium intermittently for heartburn, but it's otherwise quite well. Phil doesn't have a regular GP, but he does like to get a script for Nexium rather than buying it over the counter as you can these days, because it is cheaper if he gets it on script. Again, just highlighting this as a mythical example, Phil's about to go overseas on a work trip to source some suppliers. Forget about COVID for a minute there for the sake of this argument. And he wants to get a supply of Nexium for his trip. He doesn't have time to arrange a doctor's appointment, so he asks his mate Sarah over a game of tennis if she'd do a script for it. Are there any thoughts on that? I do see we do have a question in there, but I might just go through the a few of my thoughts there first, Ryan.
Yeah, sure.
So there can be reasons why Phil would write the script, why Phil would have the script written by Sarah. And Nexium's pretty harmless. It's, as I've just said, it's available over the counter. It's fairly side effect free. Famous last words. I know there'll be some physicians that have seen all sorts of really unusual things, but generally it's pretty harmless to take as a medication. It sounds like he's on top of his requirements for it. It's a long-standing regular medication that he's on. So all those are arguments in favour of Sarah writing the prescription. Having said that, there's probably some also really good reasons why Sarah shouldn't do it. First of all, she's not sure that he's being adequately managed by his GP or by a specialist. I think the case actually said that he doesn't have his own treating GP. Now maybe it's being managed by the pharmacist, but I'm sure that's only in limited circumstances where that can occur before a little bit more specialised involvement from medical care needs to occur. And there are risks involved there as well with writing that, and there are probably other good reasons not to write it. Things like, I mean, we all know about chest pain and heartburn, and how heartburn, everybody puts it down to being gastroesophageal reflux, but it ends up being cardiac ischemia. So that's always a bit hard to diagnose during a game of tennis, unless it's a dramatic presentation. There's also really the potential there for fragmented care. You know, someone really should be looking after Phil for everything that may be happening in his life medically, including lifestyle stuff and so on. And probably the best person there is a GP rather than Sarah, the endocrinologist. Possibility of inappropriate care. You know, is that really what Phil needs? Are we missing something? Should he be having an endoscopy? And even if it is fairly harmless, the other thing is that slippery slope that Roanne's talked about earlier.
Yeah, and Pat, you're absolutely right. I think you know, this is a good example, and we often get asked, and I think there's a question that's been posted in the chat about, you know, things that as a clinician you might be thinking of as you know, simple or relatively straightforward, uncomplicated, be that a repeat medication, be that antibiotics, but the issue is what it leads to. So, you know, ideally the starting position is to avoid that one-off prescription for something that might seem simple or uncomplicated. If you find and you know, suggest to them, look, actually that you can certainly say that might be something that you want to get some antibiotics for, but you'll need to go and see your GP. And for you all as physicians, the fantastic thing is that's actually one of the sort of tools that you can have in your kit, is to defer and say, look, actually it's much better that you get that care or get that provided by your regular GP, and because of your particular specialty, it might be outside the scope of your practice or outside your expertise, and that's a really good sort of way of putting that saying that no in a gentle way to the patient, so that they're not they're not sort of put out, or the friend or family, so that they don't think they are your patient. And certainly if you do find yourself in a situation where in the circumstances you are the best way for that friend or family member to get that one-off script, just make sure that you get them to communicate it to their usual doctor, so that their GP knows that you have had that, and then follow up with them at the earliest available opportunity as well. Pat, one of the other questions that comes up a lot in this situation is about sort of local law or rural situations, and we might talk about that. But what Phil's situation develops a little bit. What Sarah decided to write him the script. What happens next with Phil?
Yeah, well, Phil, as far as the case scenario goes, we've got Phil, he gets the script, he goes overseas, the trip doesn't go very well at all for him. The next time they get together for tennis, when he gets back, he's really quite stressed. Work hasn't gone well, he didn't get the deal that he thought he was going to get. And he's right off his tennis game as well. Says to Sarah he's not sleeping very well, he's having difficulty concentrating at work. So he asked Sarah, here comes the slippery slope, of course, if she could prescribe him something to help him sleep, just to time over for the next couple of weeks. And then he promises Sarah that he'll make an appointment with his GP after that. What's going on there, Roanne?
Yeah, so I think this is a really good example of, you know, probably something that could have been avoided at the start if Sarah had just said no. but of the situation and how she starts to get into a difficult situation. So here, really, obviously, the best thing to do would be then at that point to say, look, I know that I gave you that one-off script, but as your friend, I really think that there are some clinical issues there that you need to deal with. So maybe what you might say to Phil at that point in time is, look, Phil, I know I gave you that one-off script, but it's not really appropriate, or I don't prescribe for my friends. I think it'd be a really good idea if you went and saw your GP and have the appropriate checks before, you consider taking any more medication or getting any other medical, any other medical input in an informal sense. And I think if Sarah did continue to prescribe, there's no need for Phil then to establish that relationship, and that makes it really difficult.
Yeah, thanks. You really got to ask yourself, beyond your personal professional issues, are you doing the right thing by your friend by agreeing to do this prescription? There's far more reaching implications, isn't there? Other issues, other needing general health checks not being done, any other health issues that he's unaware of, and you just can't be objective. And also, it's really hard to ask Phil the questions that might need to be asked that would normally happen in a doctor-patient relationship.
Yeah, that's exactly right, Pat. And often what we find here is it's not the doctor that's doing the prescribing or the friend that take issue with it, but it might be that someone else finds out about it. So it might be the pharmacist. So in a small community, or your local pharmacist who knows your name might recognise that this is actually inappropriate prescribing, or it might be someone else that Phil knows. So in this case, Phil's daughter, who's training to be a paramedic, has just undergone her education about the code of conduct, which is similar for a number of the different registered health practitioners. And she's really concerned that Sarah, who she knows quite well, is actually prescribing for Phil when they're not in a formal treating relationship. And she actually considers making the report to AHPRA. So at that point, that's when we get involved, and Sarah calls our medico-legal advisory service and seeks some advice. And absolutely, if any of you found yourself in that situation, that's absolutely what we would be suggesting that you do. And so it's often, that prescription, that one-off prescription, that simple thing that you might think is okay, is what can lead to much greater problems down the track.
Yeah, Ruanne, we see this a lot, where, especially in relation to mental health, where people are getting prescriptions and prescriptions aren't being done in an objective manner by an objective doctor. It really is often a concerned relative, sometimes someone with a bit of knowledge, like a newly graduated paramedic, such as in this case. We just see that so frequently, and good on them for actually drawing that to the attention. Not so good on them from Sarah's point of view, because she may well be the subject of a notification to the regulator. But as far as Phil getting the right treatment, that's really important.
Yeah, so it's just a really good example of where what you might feel is doing one of your friends a favour in the first instance can actually lead to you finding yourself, at worst case scenario, in some sort of having some professional implications from a registration or a professional conduct investigation. But also it's not really serving Phil's purposes in that he's not getting, potentially proper continuity of care, and there may be some other either clinical consequences for him, but also it might prove awkward in your friendship moving forward. And so one of the ways that you might look at it is, is this something that is worth risking my professional reputation and registration for? Is it actually the best way that I can help Phil in this situation? And as we go through tonight, we'll look at sort of those common themes and the different situations that build on that. And sometimes having that stance about, look, I just don't prescribe for family, friends, I don't prescribe for staff, is a really good starting point. And what we've seen over time as this, as sort of awareness of some of the complications in this area develop is that policies, different organisations and facilities are bringing in their own policies. So we'd be really interested to know if you could let us know if your practice or the hospital, or you, if you're in sole private practice, have a policy about treating family, friends, or staff, and let us know, what that situation is. And while those while those results come up. Pat, what's your experience of treating colleagues?
It's actually quite challenging, as anyone who has treated colleagues, whether you know them professionally or know of them professionally or you've never heard of them before, it does have its own set of challenges. Deep down, it's quite an honour that a colleague does trust you enough to come along and see you. So keep that on board, that they've probably thought about you or heard about you, or they've seen your work. And I know I've taken family members of mine to colleagues that I know. I'd really like them to look after them because of how they work professionally. So it is that honour. However, it's also quite confronting, because you know that the colleague sitting there in front of you actually has a wealth of knowledge. They probably might even know more about whatever's wrong with them than you know, especially if they've done some sort of research in it, or if they're, the classic example is some, say, more experienced doctors who've seen it all before will go and see a newer doctor and almost lord it over them that they know far more than them. So that can be a bit of a challenge there. The other thing hand in hand with that is that the patient doctor, the patient colleague, may also already have fixed ideas of what they need. I know myself, I had a retired GP who used to come in and see me every so often with chest pain. And he did actually come up with all sorts of weird and wonderful diagnoses. And really, the challenge for me there was to try and turn around and dispel his preconceived ideas of what might be going on, and actually still try and do it quite objectively.
Yeah,
yep.
And those are really good examples, Patrick, of how that those interpersonal dynamics when it comes to treating colleagues. So the poll results are ready. So 27% of you said that you or your practice or hospital does have a policy about treating family, friends or staff or colleagues. 41% of you weren't sure, and 32% of you said there is no policy. So that might be a bit of a piece of homework for those who aren't sure after tonight, is to find out whether or not, your practice or your hospital does indeed have it. So that's a really good lead into looking at what does happen when you might be asked to treat a staff member or a colleague. Pat, can you talk us through this case study?
Absolutely. So Diane's the secretary for Harry the haematologist. She lives far away from work. She's got classic symptoms of a urinary tract infection. So she asked Harry the haematologist for a pathology form and also for a script for trimethoprim, because that's what's always worked in the past. Ruanne, what are some of the problems treating staff?
Yeah, so look, the biggest problem that we see on the medico-legal advisory service in this issue is ultimately the starting position is one of privacy. So obviously, to treat that staff member, you need to create a medical record for that person, and usually that will mean that all the other practice the staff members will have access to that person's records. So there's a concern there about potential privacy breaches of other people accessing that patient's records. The other issue might be, the feeling that you wouldn't then, as a result of that, put all the relevant information in that record, so it's not accurate. You might also find that if it's a staff member and you're actually employing that person, you might find yourself in a difficult situation where you're the treating doctor and employer, and then a workers' compensation situation might arise relevant to the treatment that you've been provided, and suddenly you're caught in a conflict of those two roles. You also might find that you're doing someone a favour rather than sort of properly treating them as you would any objective patient. And that informality, the corridor consultation can lead to there being, no notes made, or a slightly sort of difficult or less than usual provision of services in that situation. And of course, one of the obvious ones might also be that they expect to get treatment for free. So, that might sort of cause some conflict and some tension in the relationship as well. So that just gives you an idea of what some of the problems are in this sort of situation. What are the other things that you might have seen, Pat, in how these things come up?
Ruanne, I was really going to talk about the clinical notes because more often than not, where things haven't been done objectively, there's no clinical notes. The first example we had where the poor little kid was seen in the corridor, there wouldn't have been any clinical notes written there whatsoever. And what we do find is that the regulators really come down on that. There's another whole section in the code of conduct where you've got to keep a good clinical record, and it's got to be good enough so that other practitioners can take over the care of the patient and understand what's going on. And obviously you don't have that there. So sometimes the regulators do clutch a bit at that. And the reason why they clutch at it is because they just can't tell what's going on. And quite often you'll have no idea about what memory of what's going on, especially if it was a quick corridor consult, which you thought was a bit of a favour or a bit of offhanded advice. And it's amazing when things go wrong, how patients and complainants may have a different recollection of what went on compared to what you do. And as we all know, good notes are a good defence. So that really is one of the big things there. Other things that I've seen go on, it's really hard to be objective. And part of it, probably getting back to the example a bit earlier with the treating doctor and treating a colleague, is one of the best ways to be objective there is to do a proper consultation in your rooms. And I said that really slowly and carefully because it really is an important thing, because it changes the whole dynamic compared to if you're doing a quick consult or a quick side chat while you're running between patients down hospital corridors.
Yeah,
so just
absolutely.
There, right? Yeah.
Yeah, and look, we've just had a question come through about sort of quite a specific situation where from a policy or practice situation, you might be managing or juggling some complexities in terms of alternative culturally tailored care options, say for Indigenous populations. So there you've got a difficult situation where you've got the rights of staff to have culturally appropriate care, balanced against the risk of treating staff in-house, and both of those being obviously important. So from a legal point of view, and if we're sort of applying the code, and Pat, I'll ask for your sort of practical medical view on this, but we would say that the code is a starting point. The idea of the code is it's a guide. So the starting point would be, is there an alternative for the needs of that patient, which would include the culturally appropriate and tailored care, to be provided by staff other than those at the practice? If the answer to that is yes, then that would certainly be a matter of facilitating that. If the answer to that was no, then it would be, okay, if we turn our mind to the conflict issues that might arise, the lack of objectivity, the issues about privacy, confidentiality of records, and then address those, then that might be a circumstance where you could justify or explain a situation, and it would be about choosing the right clinicians to care for the right staff members or the right practice staff. And also absolutely in that situation where you've got the overarching Aboriginal Medical Service as the sort of owner operator of the practice, absolutely refer your concern or the question to them, and then make sure that that whatever happens, the services turn their mind to the issues, that there is a policy in place, regardless of, albeit being slightly different in that situation potentially, and then ensure that it's consistent. So everyone knows what they can expect, knows the starting position, and knows the alternatives, so that if a conflict does arise that can't be managed within the practice, how to then escalate those or provide care in other ways.
Yeah.
Pat, did you have anything to add from a practical point of view?
Just from the point of view of providing culturally appropriate care, again, also keep in mind that if you're working in that situation, you and your colleagues in that facility really are the experts in the field. And you really don't want to be dictated to by somebody sitting in an ivory tower in a big city, because it's very, very different. If it is some reassurance that the regulators are very aware of that as well. And I understand they've done a fair bit of training and a bit of work in that sort of field to give regard to that, because I think we do understand that patients like that, a lot of it is based on trust. As it is in any consult, of course, but it's a sort of a differing level and done with a different dynamic. So that is still something that you do need to consider, but you've got to be able to justify why you're doing it that way. But it should be relatively easy enough to be able to justify it if that's the specialised service that needs to be given, so that those patients do get the best consideration for care and also the best outcomes that they can get.
Yeah. And one of the interesting things to note is actually in the revised version of the Code of Conduct that was released last year, cultural sensitivity and culturally sensitive practices was a new section that was included specifically to address Australia and its multicultural makeup. So for that person who posted that question, go to the code in the first instance, have a read not only of section 314 about treating staff members and those close to you, but also have a read of the cultural sensitive and the sort of culturally aware provision of care. And that may be a good starting point to have a discussion with the service about, how you manage those competing interests and competing needs and ensure that everyone's on the same page and approaching that from the best sort of consistent approach. We had another question that came through about how to manage the situation where it's actually the practice that's asking you to treat colleagues, or for some of our paediatric physicians who've dialed in, it might be, where you feel pressure to treat the children of your colleagues as well. And, there might be an initial recognition that you as the paediatrician can't treat your own child, but then the easiest thing is just to send them to your colleague, down the corridor at the hospital or in the next room in private practice. And certainly, the Code of Conduct, again, if you want to decline those requests, and we would encourage you initially to find alternatives, is that's on your side to say, in the case of the practice, putting pressure on the clinician to say, look, actually, the medical board says that I shouldn't do this. And it may be that the practice in that situation is unaware. Patrick, what about our paediatricians or our other clinicians who are asked to see the children of colleagues or the children of friends, where the patient is sort of one step removed?
Yeah. I don't have a problem with that so long as you can be objective. Similar to my comments in relation to the Indigenous health services, the person best placed to decide whether they can be objective or not is probably that particular specialist. And it does happen all the time. As I said, I've taken my relatives off to see colleagues, or I've recommend when they say, "Oh, which surgeon should I see?" I say, "Well, have a chat to your GP. But if your GP is happy with so and so, they're really good, and I'd be happy for you to go and see them." So that happens. You do still need to be objective though, and one of the best ways of being objective is to still make sure that you do it as a proper appointment. Yes, you might be a little bit nice to them and get them in a bit sooner than other average people, but you don't want them taking advantage of that, or you don't want them becoming a bit dependent on you. But if you make an appointment, they get all the information before the appointment, the same as every other patient gets. They come and they sit in the waiting room, and then they're called in, and then you actually take a proper history. Always a big fan of taking history. Sometimes it's a bit of a dying art, but it really needs to be done. And examination and whatever management and so on. You still want to do that exactly the same as if it was a stranger sitting there. We have had a little question that's a bit of a sideline to that. Is it okay to do that? We'd make the appointment, use your consult time, send a letter back to the referring GP, etc. Absolutely, that's fine. At the colleague's request, yeah, that's absolutely fine. And yes, you can bulk bill them. That's sort of a tradition amongst doctors, isn't it, that a lot of us do bulk bill other doctors, not all of us. Don't expect it to happen if you happen to be a patient. I've seen doctors getting really angry out in waiting rooms because they weren't bulk billed. It's not a right. And that gets back to sending out the information beforehand. Send out the information that says how much your consults cost. Give them proper informed consent.
And Patrick, I think that question is a good example of where the wording in the code talking about someone that you have a close personal relationship with is really is sort of deliberately general, I suppose, because it may be that you know, obviously who you might consider your colleagues might be a very broad group of people. So you may have the person who you work with every day in the same practice ask you to treat them because they because you know they know you and trust your clinical opinion, but you also share rooms, you work in the same practice, you both sort of employ common staff, and that would perhaps be a situation where the closeness of that relationship would mean that you couldn't treat that person objectively, particularly if it meant that in treating them you were to discover an underlying health condition, for example, that meant that you were concerned about whether or not, you know, they were sort of able to hold up their end of managing the practice. You know, a different situation at the other end of the spectrum might be someone who's in the same specialty as you, that you know from when you're at uni together or going through training, but you haven't seen them for 15 years. You've got no common hospital appointments and you've got nothing to do with them other than, you know, both having the same specialty. And that might be a situation where you might feel that you can be objective. In any of these situations, one of the good ideas is to have a conversation about it at the start. So if you get called by one of your colleagues and they say, look, would you be happy to take me on as a patient? I know we work in the same rooms. You can turn your mind to, can I treat this person objectively? You know, am I going to be able to ask them all the questions that I would ask a regular, you know, sort of arm's length patient? And if the answer to those questions are no, and you can't treat them objectively, then it's worth actually putting an end to that right at the start and saying, look, I'm sorry, I'm really flattered, but I just can't, I don't think I can be objective. Why don't you see Dr. X or Dr. Y, who we also know are very good, who might be more at arm's length, and actually have that conversation. And if you do decide that it's okay to treat them and you can be objective, then have that conversation and say, look, I feel that I can treat you objectively. You may not use those exact words, but you know, are you comfortable with that? But also then just, you know, I suppose keep an eye on the situation, and if it does develop or escalate, that may be a situation where you say, look, if any point either of us are uncomfortable, then I will refer you back to your GP to be referred to someone else, and maybe have that discussion. And maybe that's a good time to look at one of the other questions that we've had come through, which is whether or not it's okay to renew routine long-term prescriptions for your family, you know, if the script has started and been monitored by their own GP or specialist. And Pat, I don't know what your views are about that, but my initial view in reading that question is I'm not sure why you'd want to do that. Mere convenience is not going to be viewed on by the regulator as a good enough reason. So, you know, if you are writing a script, you are individually responsible for having determined that that script is clinically appropriate for that patient. So you would be expected to do proper assessment. And if the GP is monitoring them, there'd really need to be some careful consideration of why you'd even be putting yourself in that situation. Pat, what do you think?
Yeah, interesting, Roanne, because I've certainly been in that situation plenty of times where people working in a hospital, especially when you do night shift, it's amazing how many people wander past at night time and ask you, can I just have another repeat for my thyroxine or statin or pill or whatever. And, you know, I know you're really good. They'll always tell you how good you are and how nice it is that you do it. Dead set, if you do it once, that you've got a patient for life, because they're going to keep coming and asking you. Because I think a lot of other people have said no to them in a similar circumstance. It's a convenient thing. It's most of the time going to be okay, but even to do a repeat script of a statin, for example, you've still got to have a proper consultation. You've got to know what their cholesterol is. You've got to know how long they've been on it. You've got to know if they've had any side effects, and what sort of monitoring is in place for it. A question sometimes will be, well, I went to the GP, I got 6, this is the patient talking, the colleague. I got 6 months worth of repeats, but I've lost them, and I got it a month ago, and now I just really need some more statins until I get to the GP again in 6 months. Can you just do another script for us? You'd probably get away with it, providing you're careful enough and you've satisfied yourself. But even then, you're not taking notes, you're not recording that they've said that they're on it and they had all of that. It's very unlikely that you're going to be writing that down. So the regulator will definitely be interested in that if there was a complaint. And I always get nervous when I say the words, "you'd probably get away with it," because that's generally a sign that you know that it's not really the correct thing to do, that will comply with that code of conduct.
Yeah, that made me nervous too, Pat. So I'm glad we're on the same page there. And look, one of the other things that that's come up in the questions is self-prescribing and treating yourself. We've got an article on our website that was recently published that you can look at too. But Pat, where does that come into? I know the code absolutely encourages doctors to have their own treating general practitioner and to avoid self-treatment. What are some of the other issues that come up in that situation?
Oh, self-treatment has so many problems, doesn't it? Because you're not objective. It's amazing how many times if you've been a proper patient, gone to see a proper doctor, it's amazing how often that doctor will say, "Oh no, look, you need to do this or something else first." You just don't have that sort of objectivity. It's human nature. You will often want just a little bit more, and a classic example there is, say, imaging. You've got a bit of a sore something or other, and you think you need some sort of special imaging compared to what everybody else would normally get, and what's actually the indications, what imaging is indicated for that sort of thing. You're just not objective, and then you really do go down a funny old path of sometimes over-treatment and over-investigation. The other big risk is the self-prescribing of S8s and drugs of dependence. It's unfortunately a very common circumstance that we do see. It has often started with doing something a bit simpler, or I just need a sleeping tablet, so I'll just have a temazepam, and a 25 temazepam will last me for 2 years. But it's amazing how you just see that get worse and worse and worse. And all of that stuff is recorded. Medicare have all of that information. They can hit a few buttons and find out which patients you've prescribed temazepam for. They can find out which patients you've prescribed any S8s for. The state governments can also, or the state health departments can also look at the S8s. All that data is there. Even if you do it as a private script, as some people try to do and think that they won't come to anyone's attention, it's all still recorded there, and a couple of keystrokes they can find out. And we know that the regulators will go and look at that, and they might say, some doctors might unfortunately say, "Oh, look, I only did it 3 or 4 times," and then you get the part of the investigation from the regulator and you find it's been done 200 or 300 times.
Yeah, and I think in that context too, it's important to note, obviously we've got people from all around Australia joining us this evening, and in our federated system, unfortunately that does mean that there are different rules in the different states and territories, but certainly some states and territories in Australia do in fact have legal provisions in the statutes about prescribing that prohibit doctors from self-prescribing, particularly Schedule 8 medication. So that in certainly I'd be saying, don't do that. And it's often when you get to that point that's where the pharmacist, for example, might be the trigger for a notification to the regulator or something like that. So, we'd certainly encourage everyone to follow the advice in the Code of Conduct to have your own GP so that you can get treated objectively and appropriately, and then referred on as need be to someone other than yourself.
And just a word on the pharmacists. As we all know, pharmacists are very valued parts of the medical team or the health team, and they do perform a vital role. And one of their big roles is in dispensing of medications like that, making sure that they're double checking that they're appropriate to be done. They are also generally very aware of what their obligations are, because they've got a similar code of conduct. And they are subject to mandatory reporting requirements as well. So if they see something going on like that, they will unfortunately have to grapple with whether they need to make a mandatory report to the regulators. So So
Yeah.
just be aware of those. As we know, pharmacists are a safety net, and generally that's a really good thing. I've had pharmacists save my tail on many an occasion. I'm really grateful for it, but just be a bit aware of that.
Yeah. So that's just to summarize that point, just the starting position is you shouldn't treat yourself, no matter how minor or straightforward. Even if it's a straightforward script, so not an essay or something more complicated, we'd really say to you, the best thing to do is to not write that script or to treat yourself. That have a regular GP who can do those things for you, and then you won't find yourself in any difficult situations. One of the other questions that has come in is about how when it becomes a simple question from a family member about how to a general question that they might ask you about their health or another family member's health, and whether that's okay or whether or not you can't even sort of have a general conversation with them. Pat, how do you manage those situations?
Oh, look, you're always going to have a general conversation. You have a conversation about anything that you think you know a bit about, but you've got to be really clear that it is a general conversation, and it's really good to have that little bit of armoury that you tell people, hey, look, I'm not sure, or you'd really have to go through it in great detail. You really need to go and have a chat to your GP.
Yeah.
Go and see them and see what they think. I'm always a bit wary now of telling family and friends to go and have a chat with their doctor, be it a GP or a specialist, and say, oh, look, you need to ask about this and that and something else, because it is amazing how often that story changes. And by the time we've all had it, we've all had patients come in and say, oh, the person over the back fence is a doctor who specialises in ingrown toenails, and they reckon that I really need to be on this particular medication for my heart. And it's actually amazing that when you go and have it, if you ever have the opportunity to have a chat to that person who had the friendly chit chat, they haven't said that at all.
Yeah. And I think it's really, those of us who have doctors in our families are very grateful for the opportunity to run things by them. But I think that question, as you say, Pat, really should be, is this something that I should be seeing my doctor about? Is this something that I should be taking my child to their GP about? So that's sort of the nature of the question that, of course, is okay. One of the questions that we had specifically was about if your family members are messaging you from overseas and seeking medical advice. And I suppose, again, if it's clear the context in which you're responding to those messages, and that, again, all you're doing is guiding them about whether or not that's something they need to be concerned about or need to look into, then that's, that's more of a conversation between family members. But, I certainly wouldn't be prescribing and sending medication overseas or providing them with any sort of detailed treatment that replaced the need for them to see someone who could physically examine them and treat them in person. So we're almost
back on, sorry, Roanne, it does fall back as always on having that pitter patter ready to go and being able to tell them that go and see a doctor. I've done that with my relatives overseas. They may not have taken that advice, but they needed to.
And that's a really good lead in, Pat, to our opportunities to summarise some of what we've talked about this evening. So what are the key messages that we're hoping people to have taken away from tonight? As you say, have a bit of a spiel in your toolkit. What else is good for our practitioners to remember?
Just beware that people are out there. I don't want to scare people, but it does happen. When things go wrong, they will very quickly turn around and say, hey, look, this wasn't great. This wasn't done objectively. This wasn't done thoroughly. I'm always a bit wary about that, especially if you don't have any clinical notes to back you up.
Yeah, absolutely. And I'd really say, use as lawyers, obviously, we love to rely on documentation and legislation and codes and guidelines, but really use it to your advantage. I think someone asked us when the code of conduct came into place, and it's gone through a few different iterations over the years, and certainly the idea of codifying and putting some of these guidelines in place has been more prevalent, say, in the last 10 years than maybe in 20 or 30 years. And And obviously, things can change, but it's really important, if you're not familiar with the code of conduct, have a read of that. And then if you feel that you've been put in a difficult situation by your practice, for example, use that as the starting point for a discussion within the practice, or use it also, develop that toolkit, that spiel that you might have, so that you can have your own sort of individual policy about, look, actually, I just don't treat family, or I don't see the kids of my friends, but actually I know, here are a couple of names, or go and see your GP and they'll be able to refer you to someone at X hospital or X practice. And that's a really good starting point. And just be aware of, I suppose, the changing nature of a boundary, and where a relationship might sit with one person might be different to another. And really, just if you do have a close personal relationship with someone, the starting point should be to avoid providing care to them. Patrick, did you have any final words?
Oh, one other word is, if you're not really sure, or if you find yourself getting into that unfortunate slippery slide to becoming more and more involved, where realistically it's not appropriate for you to do it, you are always welcome to give Avant a call on the medico-legal assistance service for some advice and a few management techniques. We'd always be happy to talk to you about individual things there.
Yeah, absolutely. And in the meantime, there's certainly a range of different resources on the Avant website, articles, fact sheets, and there is a fact sheet about treating your family and friends. So if you want a written reminder of any of the things that we've discussed tonight, please feel free to jump on the website and have a look at that, and a number of other different resources. As Sterling said at the start, please, when you log out, do complete the survey so that you can let us know about any other issues that you might like to know that affect your practice. And also, it may be something that you need to do to get CPD points. So that's always good too. And other than that, thank you so much for joining us this evening, and we hope you enjoy the rest of your evening.
Yeah, thanks, everyone.
Thanks.